Kane, and I'm here with HIT 292 Healthcare Reimbursement. And we are now on week 15, which is chapter 10, Value-Based Purchasing in your book. If you want to follow along with me, I'm starting on page 273. If you look at your syllabus, you can see that we're on unit objectives 9.1.8 and 9.1.11. That's what we're focusing on this week. This is our last lecture video for this class for this semester. You have a discussion on ACOs this week, an assignment on RUGs to PDPM, and a quiz on chapter 10. But let's get started with our video here, going through chapter 10. What are our learning objectives? Well, we want to talk about the origins and evolution of value-based purchasing and pay-for-performance, which you've already covered in other classes, so this is just kind of reinforcing what you've already learned. We'll describe key characteristics of value-based purchasing programs implemented by CMS for the various healthcare settings and payment systems. We'll also explain how compliance with CMS value-based purchasing programs affects healthcare reimbursement for facility, entity, or provider. So what is value-based purchasing? Good question. According to your book, which we're going with, value-based purchasing, or VBP, and pay-for-performance, P4P, systems reflect widespread movement in healthcare, the movement seeking to improve quality, safety, efficiency, and value of healthcare. So they're trying to link quality, performance, and payment is what they're trying to do. They're trying to increase efficiency by reducing the cost per beneficiary or cost per patient. That's what they mean by efficiency. So they're trying to improve quality and patient safety, increase efficiency, and prove that healthcare, really get the value out of it. And they do that by looking at quality, performance, and linking it to payment. So what are the characteristics of both value-based purchasing and pay-for-performance? Well, they definitely have measurement. They collect data and analyze it. They make it transparent because they provide the information to the public so that people can make informed decisions, and then they hold accountable, organizations and individuals accountable through financial penalties if they don't provide information or if they don't provide it timely, or if the information shows that they've had bad performance. So what are the goals of VBP and P4P? Well, they want to improve clinical quality, improve the cost and affordability of healthcare, improve patient outcomes, and improve the patient experience for receiving care. So we're going to talk a lot about patient satisfaction or patient experience. IHI has a triple, note another spelling error here by AHIMA, triple aim. And the triple aim is improving the patient's experience of their care, improving the health of populations, and reducing the per capita cost of healthcare. And hopefully by now in the program you have read all three of these. If you haven't, I would encourage you to take some time between the end of this semester and the start of the spring semester in January and pull each of these up and read through them. I think it would really help you understand the context of how these programs came into being and what is it being attempted on a national level with healthcare. So there have been some private sector initiatives. You may have heard of Leapfrog Group. That was really popular, say 15 years ago. It was really hot to make sure that you were participating with Leapfrog. Their goal was to positively affect the quality and affordability of healthcare by leaping forward, by being transparent and having organizations voluntarily provide their numbers to show their performance. There's something else called Altarum Bridges to Excellence, which you can look up if you're really interested in it. There's IHA of California that has some performance measures. There's the National Alliance trying to improve the value of healthcare, and again, you can go out and take a look at that. And they're a healthcare purchaser coalition. Then there's NCQA, and hopefully you've been exposed to NCQA by now. If you haven't, in the spring there's a class called Quality Management, and I'm sure at some point we will touch on NCQA. And they are looking to improve the quality of healthcare as well. There has been little evidence to support the use of VBP and P4P systems despite their proliferation. Um, there are lots of questions, and this again, another error by AHEMA. Many questions remain about how to design and implement these programs to achieve their stated goals. This is a good class discussion question. Why are we still using pay-for-performance and value-based purchasing if their efficacy has not been proven? And that's a great question, and something certainly that we'll probably discuss at some point before you graduate. The biggest reason I would say, if you go out and look, is the government has adopted these and they're not going to give them up. It gives them a way to try and hold providers and organizations accountable for their care. Not always fairly, but it is a way for them to manage the money. They sound good in practice, but they're challenging in reality. And as many good intentions are by governments and by legislators and politicians, they have great intentions. But when you actualize some of these things, sometimes they don't always show any benefit or what have you for several years or if ever. So, like any government program, they can become easily entrenched over time. And I'm going to leave it there. I have worked in healthcare environments under all of these before VBP and P4P, and then under VBP, and then under P4P. And every single one has their good points and bad points. So there's no point in trying to argue which one's better than another and all of that sort of thing. They all have their challenges, they all have their benefits, and they're all trying to do good things. They're ultimately trying to help patients. And I think that that's one of the things to keep in mind, that until a better solution comes along, trying to help patients is not a bad thing. So here we go into advantages and disadvantages of value-based purchasing and pay-for-performance, and they list those out there. Again, there are benefits and challenges to everything in life, and they're listed for you here. There's reward-based and penalty-based models, and they're just exactly what you can imagine, carrots and sticks. Have you heard of a patient-centered medical home, PCMH? These started, 7 to 10 years ago. They really came into being. And what their goal was is to try to meet all the healthcare needs of the patients in one place, to coordinate everything so that a patient wasn't going in several different directions depending on what their care was, but to have one practice, so to speak, or one provider who took care of everything for that patient and coordinated it. And it was thought to help improve the efficiency of healthcare and the quality too, because if you have multiple people managing something, there's a chance that something could get missed, whereas if one person is managing it or one group, there was a chance that it would be more closely carefully observed and managed. So that's what's behind that. So these are the features of PCMH and what they were trying to do and how they worked and fit in with some other things that were happening. And there still are PCMHs. You can become you can still get that designation. A practice can today. And what they have found is they have found some positive effects. There's not enough evidence yet to determine the effects on clinical and economic outcomes, and there's no evidence for overall cost savings. And that's just what they found so far. It may change with time, who knows? Accountable care organizations, now these only started, I would say, about 5 years ago, 7 years ago at the very most, probably closer to 5 years ago. But these have been set up, and they are a set of providers, not necessarily um, all owned by the same one, but often are, who are jointly held accountable for achieving quality improvements, reductions in spending, and the health and healthcare costs of the designated population. There are three essential characteristics. You have to be able to manage the patients across the entire continuum of care. That includes acute, ambulatory, and post-acute health services. You have to make sure you can prospectively plan budgets and resource needs, and you have to be of sufficient size to support comprehensive, valid, and reliable measurement of performance. Make sure you know this information. Not that you don't need to know the stuff that came before, because you do, but this is very important to know about ACOs. They were part of the Medicare Shared Savings Program. Make sure you understand what that term is, and that they are a legal entity recognized under state law. They have a 3-year agreement with CMS. So the ACO, when they sign up with CMS, they're committing themselves to 3 years under the ACO agreement. And they coordinate the care of traditional Medicare beneficiaries. They're accountable for the quality, cost, and overall care of all the beneficiaries that are assigned to it. So how does it work? Medicare beneficiaries are assigned to an ACO based on their claim history. So if someone who's a Medicare beneficiary has been going to the same doctor for the last 3 years, that's probably who they're going to get assigned to if they're in an ACO. The beneficiary can choose to use providers within the ACO or outside of the ACO, or both. The ACO receives reward or shared savings if targets are met, and that's quality, efficiency, cost, all of that. The ACO and the non-ACO providers are still paid under regular PPS, although that is changing. So make sure, because these slides are from 2018, so that, and I know that was changing shortly thereafter, so I would be careful about that one. There are 3 different programs. There's the MSSP, there's the Next Generation ACO demonstration project, and then the Medicare ACO Track 1 Plus model. Again, this was 2018, and this may have changed since then, so it's good information to know. But I believe it has changed since then. I don't want to confuse you, but just be careful about this information. So I would say at this point, because AHIMA has not updated this information, go with it. But just know that if you go out today to CMS, it may very well be different. And this just explains about who's assuming downside risk, which means shared losses, if they don't meet the expected cost model. So this gives you an idea of how it works, that you have the expected expenditure amount for the ACO, and in this case they're saying $9 million. The higher the quality, the greater the share of savings is provided to the ACO. So in year 1, expenditures equal 10 million, so there's no shared savings. ACO does not have to repay Medicare. In year 2, expenditures are 8 million, the savings 1 million are shared between Medicare and the ACO. In year 3, if the ACO's expenditures are 7 million, the shared savings is 2 million, and that is split between Medicare and the ACO. So you can see there's potential here, good potential here to benefit both Medicare and the ACO. This just talks about how patient assignment or attribution works using the information from the review year to assign them the next year and how that works. And it can be done prospectively, performance year, or hybrid. These are the three different ways it can be assigned or attributed, patients can be. And then performance measures, these are quantitative tools. They provide an indication of performance in relation to specified processes or outcomes. You have structure measures, such as their health information technology that they're using. Is it CERT? Is it CHRTA is what I meant. And is it capable of doing certain things like CPOE and electronic prescription ordering and things like that. Then you get into process measures. How are they doing with treatment guidelines or standards of care, best practice, those types of things. And then outcome measures, and that's where you get into mortality rates and things like that. So CMS is really trying to link quality to reimbursement. They want better care for individuals, they want better health for the population, and they want lower costs through these improvements. Their strategy is to make care safer by reducing harm, help patients and their family be more involved in their care, promote effective communication and coordination of care, work with communities to help people live healthier lives. He must have a rough time here. There's another spelling error. Promote effective prevention and treatment of chronic disease and make care affordable. Please make sure you know what CMS's quality strategy is. It's important you know these things. Quality reporting program. The facility or provider will maintain full payment for services when it successfully participates in a quality measure reporting program. There's so much quality reporting that goes on. Having worked in quality management for a few years, I was directly involved in reporting this information, gathering, analyzing, and reporting this information. So I understand exactly what they're talking about. I'm looking at your book because I kind of jumped ahead here. And I haven't always kept you on the page number, and I apologize for that. Let's see here. We talked through attribution. I would say that we are getting close to page 286. There's table 10.1 where it gives you some selected performance dimensions and examples. These are really good to look at. Also, you can look at table 10.2 on page 287. It shows you some factors that are involved in value-based purchasing pay for performance systems. It gives you the factors and the features. And I think those are well worth looking at. And then it starts going into some of the specifics where, it talks about NQF and their composite measures. Hopefully we'll see that here as we go forward. I may have skipped too far in the slides, and if I have, I'm sorry about that. Actually, yes. So let me back up. All right, let me back up to performance measures. Yes. And that's what I was just talking about, those two. And we talked about structure versus process versus outcome. That's bottom of page 287, top of 288. In this class, I don't know that we're going to talk about NQF. We are not this time around. But NQF and HEDIS, I'm sure you will have those at some point if you haven't already in terms of those measures. And if not, in your spare time, when you're out surfing the net, look up NQF and look up HEDIS and take a look at those. It's very interesting to see what some of those individual measures are. So, okay, back to quality reporting programs. Bottom of page 291. So you have measures that are specific to the healthcare setting. And these measures, if they are not reported and not reported timely or don't meet the thresholds, you get that 2% reduction for failure to successfully participate. And that can be, well, unfortunately, I know of an organization that lost $100,000 with their 2% reduction. I know of another that lost more than that. So, depending on the size of the organization, it can be that 2% can be pretty significant. Just saying. So, value-based purchasing programs. This visual is also on page 293. It's figure 10.4, CMS National Quality Strategy Domains. These are the NQS domains that they're looking for you to report on with value-based purchasing programs. They want the data in these areas: communication and core coordination, community population health, effective clinical care, efficiency and cost reduction, patient safety, and person and caregiver-centered experience and outcomes, which is your patient experience surveys. So they gather up all this information and take a look at it and see how you score against other organizations and against their threshold, and that determines what your reimbursement is going to look like. There is a hospital value-based purchasing program. We've talked about IPPS before, so I'm not going to go into it here. But you need to know what it is. Make sure you know the information on this slide. This just gives you an example, looking at congestive heart failure, 30-day mortality rate, whether or not discharge instructions were provided, and those types of things, all the different things that they're looking at, those different domains. And then they look at HACs, the hospital-acquired conditions, and they list those for you here. And talks about how payment can be reduced with if your HAC scores are pretty low. And then there's the hospital readmission reduction program that's been going on for a long time, trying to get readmissions down. And I understand with COVID that they've actually suspended this because they've had so many COVID readmissions. So I understand during COVID, this piece has been suspended, at least for a while, which is good for hospitals. Okay, so it looks at these areas for readmissions. And this is also on page 296 if you're looking in your book. It goes into some detail. End-stage renal disease, there is a quality incentive program for that because, of course, that's PPS. And there's clinical reporting and safety, those 3 parts. There's one for home health in these states. And you will notice Iowa. We are one of them. And this just goes through how that works and that there's an incentive or reduction for each year. So you can see we're already up to 6% versus 7% versus 8%. So it's really hopefully incentivizing people to have improved performance rather than deficient performance. Then you've got skilled nursing or SNF facilities. They have PPS, so of course they have a quality reporting program. They look at 30-day all-cause readmission measures and 30-day potentially preventable readmissions. And then you have quality payment program, which is and this should be MACRA. Good grief, Mahima's really having trouble with this slide presentation. I wish I could change it to correct it, but I can't. But anyway, that should be MACRA. Just switch the R and the C around. We've talked about MACRA, how that's physician payment, and they have to have quality measures, and they have cost-saving goals. You have MIPS and APMs. MIPS is usually for individual physicians, And then you have APMs for the advanced alternative payment models, usually somewhat the ACO track. And this takes the old meaningful use information, not all of it, but much of it, and the PQS system, which ended in 2018 with fiscal year 2017, and then their payment modifier program, put it all into one model, and then they get bonuses based on their performance metrics. And again, notice that it increases, the incentive and penalties increase each year until it reaches 9% in 2022. And this just gives you an example of APMs. And this goes further into APMs. And this is pages 298 and 299 in your book. Future is, they've asked CMS to make sure that they include social risk factors or social demographic status within the value-based payment framework. And these include income, education, race and ethnicity, employment, disability, community resources, and social support. So they're asking them to refine it further, including these other things when they factor in performance. And that is it for Chapter 10. And that is it for us here in this class of HIT 292. That is the last chapter that we're going to cover in the book, because that's the last chapter in the book. So, as we talked about, you've got an online discussion this week with ACOs. You've got an assignment on looking at from RUGs to PDPM, how that change has occurred. Quiz over Chapter 10. Next week, you have an online discussion, an assignment on computer-assisted coding, and then your reflective paper, and you are finished. Hard to believe, time has just flown. Take care, and hopefully I will see you next semester. And if you need me in the interim, you know how to find me through email. Thanks.